We proposed the concept to ASCO, the American Society of Clinical Oncology, recognizing that extravasation management requires significant interdisciplinary collaboration and rapid action. So there can occasionally be uncertainty or lack of clear guidance when an extravasation event occurs. And our objective was to really look at this evidence with the expert panel to create a resource to support oncology teams overall. We hope that the guideline can help mitigate harm and improve patient outcomes.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between.
Hello, and welcome to the ONS podcast. I'm your host, Chelsea Backler, Oncology Clinical Specialist at ONS. And today we're talking with Caroline Clark, Director of Guidelines and Quality at ONS, about the American Society of Clinical Oncology, or ASCO, and ONS Antineoplastic Extravasation Guideline, and the takeaways for oncology nursing. This episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation linked in the notes. Thanks for joining us today, Caroline.
Thank you so much. Happy to be here.
To begin, can you maybe give us an overview of what antineoplastic extravasation is and maybe explain why ONS and ASCO wanted to create a resource for it?
An extravasation happens when an agent that has the potential to cause underlying tissue damage escapes the intended site of delivery. So the focus of this guideline was specifically on intravenous antineoplastic extravasation, or when a vesicant or an irritant with vesicant properties leaks out of the vascular space. So this can cause an injury to the patient that's influenced by several factors. That includes the specific drug that was involved in the extravasation, whether it was DNA binding, how much extravasated, the affected area, and individual patient characteristics. So the severity of these events can vary widely, with the potential to cause erythema in that space all the way to ulceration and necrosis. Regarding rationale, because of the potential to cause harm to the patient, we proposed the concept to ASCO, the American Society of Clinical Oncology, recognizing that extravasation management requires significant interdisciplinary collaboration and rapid action. So there can occasionally be uncertainty or lack of clear guidance when an extravasation event occurs. And our objective was to really look at this evidence with the expert panel to create a resource to support oncology teams overall. And we hope that the guideline can help mitigate harm and improve patient outcomes. Regarding organizations coming together to collaborate on guidelines, it helps present a consistent message. And we're really happy that ASCO signed on to work together on this.
Yeah, and I'm sure people listening to the podcast can vouch if they've experienced an extravasation with one of their patients. It can be a lot to try to figure out what is my next steps. You want to mitigate harm. You want to act as quickly as possible. So having clear-cut guidelines and steps that you can take is super helpful for, nurses and other people on the care team at the point of care. So, this is such a great contribution to oncology nursing. Super happy that we were able to bring this to the membership. Let's talk a little bit about the guideline panel that actually worked on this. So how did this panel get put together, and what was the role of each group or individual that was involved?
We followed the National Academy's Clinical Practice Guidelines We Can Trust guidance for developing a panel. And this was a volunteer commitment and a long volunteer commitment. So really so much gratitude to the panel. There's an application process, and conflict of interest is reviewed to make sure that our panelists and decision makers remain objective and unbiased. For this guideline, we wanted good representation of key people that might be involved if an extravasation occurs. And we wanted people that have experience in this space. So our team consisted of 2 medical oncologists, a clinical pharmacist, nursing professionals, and a patient representative. And I cannot stress enough the importance and the value of having a patient participate on the panel. And she did so throughout all of the activities with the guideline over the course of about a year and a half. It was really great to hear firsthand her perspective and have her weigh in on patient preferences and values throughout the experience. And then for the nursing roles, 2 infusion nurses were included. And these are often the individuals who are first to identify an extravasation has happened or is suspected. There was also advanced practice nurses on the panel, a nurse practitioner, and several clinical nurse specialists with experience at both the system level and the unit level in management, monitoring, photography, and policy development around extravasation. The primary role of the panel included identifying the key outcomes related to extravasation, evaluating the evidence, and using that evidence to collaboratively establish recommendations. And then beyond that, we had the methodologist team providing guidance. And within ONS, our internal team does not explicitly vote on recommendations, but instead we support the panel. And that included myself, you, Chelsea, thank you so much, and our research specialists all working together to sort of facilitate the process and the dissemination activities around the guideline.
Yeah, this was actually a really exciting project to be involved in. And as you said, it was kind of a long project, about 1.5 years that we were working on this, but the panel was so engaged the entire way through and really excited to lend their expertise and be part of the process to develop this guideline. So it was really, really fulfilling for me to watch as an ONS staff member. Can you talk a little bit next about the processes and tools that were used to put the guideline together? And then what outcomes did the panel really feel and determine were important as it related to this guideline?
Regarding the how, right? At ONS, we use GRADE methodology, and that's short for grading of recommendations, assessment, development, and evaluation. So much easier to say just GRADE. It's an internationally recognized framework that ensures that our guidelines are transparent, rigorous, and consistent, and it's commonly used for clinical practice guideline development. You'll see GRADE listed quite a bit. The process starts with the panel determining those outcomes that are important and the development of a PICO question. So if you're not familiar with the PICO question, it stands for population, intervention, comparison, and outcome. And it's just a way to ask the clinical question to then get into the literature and dive in. So for this case, the population, adult patients receiving antineoplastic vesicants or irritants with vesicant properties, interventions of antidotes, compresses, surgical referral or escalation of care, and a comparison to standard of care or not doing those interventions. So the outcomes, the panel really identified and ranked outcomes that mattered most with extravasation. And not surprising, one of the first was tissue necrosis. Like, how are we going to prevent tissue necrosis, preserve tissue? The next was pain, quality of life, delays in cancer treatment. How is an extravasation going to delay cancer treatment that's vital to the patient? Is an extravasation also going to result in hospitalization or additional surgical interventions that would be burdensome to the patient? So these are kind of all of the outcomes that we asked our systematic review team to then get into the evidence and explore. So we had the systematic review team that went in then and summarized the data, and the panel applied the GRADE criteria, rating quality of evidence, and weighing factors like the patient preferences, costs, and feasibility of an intervention. And from there, they developed their recommendations. You'll see with GRADE, recommendations are rated as strong, conditional, or noted to be a knowledge gap. And you'll notice a certainty of evidence from very low to low, moderate, and high. And this rating is based on study design and risk of bias in the evidence. There's a nice chart within the guideline that explains more about what the recommendation and the certainty means.
Yeah, so there's a couple of things that you mentioned that I just wanted to really lean into, which was the outcomes. And so I think it's super important to kind of clue into or tune into really that extravasation, as the extravasation can be so devastating beyond even just the extravasation itself, right? Which again can cause severe reactions like necrosis, pain, but then also, like you said, delays in cancer treatment. If a patient has a significant extravasation, especially if they have an extravasation of a central line, now they need something else, that can cause significant delays. It can cause the patient a lot of anxiety about what that means for their treatment and their cancer. And so I feel like those things were really important for us to make sure that we were looking at. And then I think the other thing that I have found to be so important in both of the guidelines that I've worked on is that weighing of the patient preferences. So thinking about things like, okay, this intervention, maybe it's effective, but is it feasible for the patient? Is it something that is going to be so cost prohibitive that it's not going to be accessible to people? or it's such a specialized treatment that patients who live in rural places are not going to be able to access it. And taking all of that into account as the guideline panel was making their recommendations, I think was so important. And I think that's too where that patient representative's voice really came in so strongly in terms of giving us that patient perspective of how doing these interventions might land with a patient and making sure we're keeping that in mind. So I just wanted to point out those couple of things that I thought were so important in the process. Each recommendation in the guideline has a complete summary of the evidence, the benefits, the harms and burdens, and a few other things. Can you talk about the strategy behind putting these recommendations together in this particular format?
This is more the grade format, and it's how our ONS guidelines are formatted. And the strategy really behind it is to provide decision makers with clear evidence-based rationale for each recommendation. Every recommendation begins with that summary of evidence. So this is going to be, how many studies did the panel review, what patient population was included, and the size of the sample, and the outcomes assessed. So for example, we have recommendation 1. When evaluating antidote use for extravasation, the panel looked at outcomes like tissue necrosis. And among 9 out of 10 studies, the incidence of tissue necrosis with antidote use ranged from 0 to 8.3%. And then the panel systematically weighs benefits against potential harms. And as you stated, Chelsea considers those patient values and preferences, but also in a systematic way, using an evidence to decision framework that helps generate the discussion amongst the panel, including the patient, and evaluates like practical factors, cost, equity, accessibility. And these discussions are documented to give a good perspective on why the recommendation was made. So overall, antidotes have mild reversible side effects, but extravasation carries significant morbidity. And this is why ultimately a strong recommendation was made in favor of antidotes in recommendation 1, which did not include taxanes. And we can talk a little bit more about that in a few minutes. The structured format is really just meant to help facilitate decision-making for the clinicians and patients. So I hope this kind of reflects like the multiple angles that the panel looked at these.
It was a very structured process for sure that the panel walked through, definitely with the help and the guidance of the entire team to kind of walk them through all of those steps for each of the recommendations. So the panel noted that there were multiple co-interventions used to manage extravasation. And that was kind of posed a challenge in the guideline. Can you explain and highlight some of the other key challenges that the panel faced?
Yeah, I can explain the multiple co-interventions, and I think nurses are really going to be tuned into this. So when you have an extravasation, our panelists are sitting there and saying, when this happens, we're doing many things at the same time. So you may be pulling the line, elevating an extremity, applying a compress, or giving an antidote, doing follow-up care with the patient and instructing them on compresses at home. So in that regard, if you have a positive outcome and the site looks good, you're not really sure what specific intervention produced that positive outcome. And this was kind of present in the literature as well. Multiple interventions were done in the studies, so it became less clear of what intervention helped the most. One issue with the evidence specifically was it really failed to clearly separate subgroups by cancer type, by agent extravasated, and then the specific outcome to that specific extravasation. The volume that was extravasated, we had to kind of pull that out of the literature whenever we could find it, but sometimes and often it wasn't explicitly stated. And then where the extravasation occurred, was it peripheral? Was it in a chest wall? Some of the problems with not kind of separating subgroups, for instance, like if you combine outcomes from a taxane extravasation with those from an anthracycline, the severity levels might differ significantly. And speaking of, a challenge also was dealing with the extravasation of taxanes, specifically paclitaxel and docetaxel. So unlike some other agents like anthracyclines that are DNA binding, there's less certainty about these particular drugs leading to severe complications. And the panel opted to really look at this separately. The supporting evidence is limited, so the recommendation in favor of using an antidote for paclitaxel and docetaxel was considered conditional. Meaning really that you're going to have to probably weigh patient preferences and values, think of the case that's in front of you, some decision making around whether or not to administer an antidote in this case. Other just like challenges that I think I might have mentioned, it's lower level evidence in extravasation. You're not going to have a randomized controlled trial about extravasation. So lower level evidence like non-randomized trials, observational or case series, they're going to lend themselves to a higher risk of bias. So that was one of the challenges.
And I think it was a really rich conversation that the panel had, I feel like, regarding the multiple co-interventions and just the evidence in general surrounding antidotes in terms of like, maybe it wasn't the most robust and wide array of evidence that we would love to see for a guideline. But then the panel really sat down and talked about, like you said, the risk of side effects with an antidote is relatively low versus we know that the risk with an anthracycline or another type of vesicant extravasation can be significant. And so really kind of weighing risks versus benefits as the panel was talking about their recommendation led to a lot of really good conversation back and forth amongst the panel members, which was really great to see. So one of my favorite things in the guideline is the flow chart. The guideline includes a flow chart of basically what to do if an extravasation is suspected. Can you explain a little bit of basically how this kind of came to be, how it was put together, and really how this could be utilized in practice?
It is one of my favorite things too, Chelsea. The panel, I think from the onset, really wanted to make sure that we had something visual for our readers to reference, and they combine both evidence from the systematic review, other scholarly sources, and their real-world clinical experience to make this one-page supplementary algorithm. They wanted it to be comprehensive, easy to follow, and they included not only those acute management steps, right? Like the in the moment, what do I do? But also guidance on how do I document this? And then what are the objective and subjective assessment factors to look at? What am I going to tell the patient? In practice, just for use of that, I would first compare it to your current processes and identify any gaps to inform policies in your individual institutions. Really kind of emphasizing that this is an interdisciplinary guideline. So get it out there to other teams beyond nursing so they have the opportunity to review it and discuss how it fits in their workflows, how it might impact different departments. Certainly would encourage the availability of an antidote list that's easily accessible. And check on documentation that you're kind of hitting all those documentation points.
I would say for sure that the guideline in general, but also the algorithm is really a great kind of springboard for teams to kind of come together and evaluate, like you say, their current policies and procedures. I think making sure you have all the right people at the table for that conversation, as like you say, it is interdisciplinary. So make sure you have obviously nursing and pharmacy, physicians, advanced practice providers, like make sure all of the key players at this are at the table for the conversation. You know, since this again isn't managed in a silo, extravasation requires a lot of different people to be involved, and it can be a long lasting thing too. So, you know, the infusion nurse might treat the patient initially, but then that clinic team is going to be the one potentially following up with that patient long term after their extravasation. And so making sure that kind of all the steps of that continuum of care for this patient with that extravasation are addressed in policies and procedures, I think really is going to be helpful for making sure that everybody's taking a standardized approach based on the evidence. So really excited to hear feedback from anybody that's using the algorithm and how it's working for them. As a CNS, I know a good algorithm is fantastic. I love it. Let's talk a little bit about some of the guidelines limitations. What are some of the areas that need further exploration and need more research?
We talked about the certainty of the evidence. In this evidence, there was very low certainty in the evidence. There was a limited number of studies. They weren't your highest quality studies because they couldn't necessarily be that with the topic of extravasation. And they were also somewhat dated. So that's definitely a limitation. The guidelines definitely don't take place of clinician expertise. They're not intended to cover every situation, but a situation that keeps coming up and that we should kind of talk about as a limitation is we're seeing these case reports of tissue injury with antibody drug conjugate extravasation. And there's still not enough evidence or information to inform care, especially around the use of antidotes with those agents. So this still needs to be addressed on a case-by-case basis we still need publication of those case studies, what was done and outcomes to help inform direction. I think one of the other areas, and it is related when deciding on a compress for agents without a clear recommended strategy, that you have to really consider cold compresses are for vasoconstriction. They're going to limit the spread of the extravasated substance. And then warm compresses are going to help disperse an agent. So if you don't really have a clearly assigned cold or warm compress, you're going to need to look at mechanism of action of that particular agent. Is there pain? Is there swelling? Patient comfort? And that, again, is going to be a case-by-case decision.
And I think this is another highlight to needing to make sure that this is an interdisciplinary conversation. So I could see that this would be a situation where if this is a nurse having a patient who has an infiltration of an antibody drug conjugate or an agent who we don't know whether it's supposed to be a cool or warm compress, bringing in your pharmacy colleagues to have a conversation about what's the mechanism of action of this drug? How does this work? How much of the drug was extravasated? And I think there's just a lot of components that have to go into that conversation. And again, just making sure you have all the right people at the table to try to be as informed as you can as you make a decision and discuss with the patient.
I think that's a good point. And I think, right, sometimes it's iterative, like what are we going to learn from practice that's going on now, like in communities, in our discussions with members, like how are you addressing this in practice? What are you seeing? Things like that, I think will help to build upon the body of evidence related to extravasation management in these novel agents.
Yeah, we do at ONS get questions into our inbox on the clinical team about ADCs specifically and looking for some guidance on should we not be giving these peripherally anymore? How do we handle extravasation of these agents? And every time I have a conversation with a member who writes in about that, it is usually telling them like the evidence is very limited. There are case reports. And so really encouraging them, if you are seeing this in your practice, like please, 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 like consider publishing what you're seeing and the interventions that you use, because it's really only going to help inform future recommendations that can be made about these things. So definitely a call for anyone in practice to be publishing what you're seeing, especially with these novel agents. So what nursing implications can we take from this project and where do we see the research going from here?
So I think beyond just the acute management, right, that early part of the algorithm is to ensure thorough documentation regarding extravasation. So whether you're on electronic documentation on paper, are the prompts there for the nurse to capture all of the factors that should be captured regarding that extravasation, the size, the measurement, what the patient's complaints, is there redness, things like that. And then within the teams, right, everyone should know where to find that initial extravasation assessment so that, as you said, Chelsea, like later on, if they're in a different clinic, they have something to go by to see how the extravasation is, healing or progressing. I think standardizing assessment of objective and subjective data, just being consistent in the way we approach extravasation assessment. The patient education on care at home is important, and nurses are often the ones that are going to be providing patient education so that the patient has a clear idea of when to call the team and seek follow-up, that they know if compresses are indicated, how often they should be doing that, what they should be using more and more cool compresses. If they have a fever that they need to call, or if they have pain and their pain is not under control, they may need to be assessed earlier. I think there's an importance here too to our novice nurses, our novice oncology nurses, and their preceptors. As we talked about before, could be anxiety provoking for the whole team and the patient. So we want to increase the confidence in management. So I think using these resources for onboarding novice oncology nurses is important. So you talked about also the research perspective here. So we want consistent methods to evaluate an extravasation. So there is the CTCAE criteria, but there really are opportunities for other tools to be developed and validated using patient-reported outcome measures tailored to extravasation might help create follow-up protocols or create some evidence regarding follow-up protocols Recommendations for these follow-ups vary widely across the literature in both duration and frequency, like how many weeks should a patient be seen. So any rationale in the research realm that could help standardize a follow-up protocol would be great.
Yeah, I remember that was something that varied quite a bit in terms of how often should we be following up with the patient? Does that need to be in person? Like, do we need to have them coming in? Do we just need to do follow-up phone calls? And then who does that follow-up? I think were a lot of the questions that came up from the panel as well. The other kind of important thing that you mentioned that I wanted to go back to was, you talked about novice nurses. I think too, extravasation, hopefully, is a very rare event in general. We've come a long way in terms of vascular access for patients and skill set of people placing those access devices. And so I think it's really reduced the number of extravasations that we tend to see. And so it's a low volume, but a very high risk event. And so I think even having, maybe if this is a competency days topic, or if you do like skills blitzes in your unit, this may be a really great topic, especially with the guideline just coming out, to have everybody brush up. Because if you have a unit of how many nurses who are doing infusions, even if you have one extravasation, not everyone in the unit is always seeing that. So I think it's always great for even experienced nurses to brush up on, okay, if an extravasation happens, what do I do? And revisiting that regularly so that if it does actually end up happening to their patient, they feel more prepared. And it's something that's kind of been ingrained in them and been revisited regularly so that they know what to do in that situation. So kind of like when you have a patient who has a reaction, if you have anaphylaxis, you're hoping that's pretty rare, but you want to know what to do in that situation because it can be very acute. So similar type of situation that I think good to revisit and, brush up those skills regularly and hope that you never need them. But if you do, then you feel ready. So what are some additional resources for healthcare professionals and patients who might want to learn more about this?
I think the other supplement in the guideline is the evidence to decision framework, and it really shows the depth of discussion behind every recommendation in light of the limitations of the evidence and the specific studies, and that guided the decision. So I think it might be helpful in evaluating your own policies or highlighting it to your teams that have that vested interest in extravasation management.
Awesome. Any other final comments that you have about the guideline process, the guideline team, or this topic in general?
I think just that it was a great team, and kudos to the team for really investing their time and energy to making something like this guideline that's so usable, would be easily implemented at the point of care. I think we talked a little bit about anxiety and kind of confidence, and we hope that the use of the guidelines will help standardize an approach and help nurses and teams be more confident when an extravasation happens and what the immediate steps are, and then what follow-up management looks like.
Well, thank you so much for chatting about this with me. It was so lovely to work on this with you and with the entire extravasation guideline team.
Thanks so much.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.